I'm Daphne Wood. She's our friend. Kind of. I don't know. Anyway, so I am a nurse, like they said. I'm a heart failure nurse navigator at Moses Cone in the heart failure clinic and in the hospital. Just a little background. I've been a nurse there for 20 years. This is my 20th year, believe it or not. I know, I'm incredibly young. And about, I guess, 4 years ago, Jackie and I both kind of started around the same time. And as many of you know, the community paramedicine program was already going at that time, but was a little discombobulated, not very organized, and so we decided that we would try to make it a bit more structured to help benefit the paramedics, obviously, because we kind of knew what was happening on our side, but they didn't always really know what was happening on their side. So this is just a little bit about our program and kind of what Jackie and I do. So, you know, I have to give you the 411 about heart failure. So obviously, it's kind of categorized as a clinical syndrome, which is caused by symptoms of pump failure or that are structural or functional changes that impair the heart's ability to fill or eject blood. So that can come from a myriad of things. Drug use, an MI is probably the main cause, valve problems, a bunch of different things can cause heart failure. So just want you to be thinking about that when you take care of people with heart failure. So why do we care? Obviously, the incidence is on the rise. So, you know, as of 2018, there are about, I think the number now is about 8 million people with heart failure in the United States. And that's projected to rise by 46% in 2030. And, you know, you may ask, why is it growing so much? Obviously, our population is getting older. People are living longer. The prevalence of risk factors are more and more. So more people smoke, more people are having MIs, you know, heart disease is on the rise. The people who used to die a long time ago, thanks to you guys, are surviving MIs. So heart failure is on the rise because of that. Okay. So the biggest thing for us is that bottom number down there. 50% of these people will die within 5 years when they're admitted to the hospital. So I have 10 people that we take care of, 5 of those will be dead. 4% die during the hospitalization, 10% die within 30 days, 20% or greater than 20% die within 180 days, and around 30% die within 1 year of an acute heart failure exacerbation. That's a lot of people. So in terms of what our clinic does, and the intent is to help these numbers.
Questions? You guys are so quiet.
Okay, so I kind of just included this one because I think it's important to know that, you know, heart failure is not like having cancer. You don't get your diagnosis and then have this sudden downward spiral where you're, you know, you don't do well. These people do well. All these are hospitalizations. They do well. I mean, they do poorly, and then they do well, and then they do poorly again, hospitalized, and then they do well again. So every time they're hospitalized, then our heart failure director, Dr. Muslim, says that it's kind of a hit for their heart. As you can see, every time they're hospitalized, they come back a little bit lower than they were before. So it's kind of like more of a chronic decline. The disease continues to progress. They never get, you know, fully better. So just something to think about. Every time that we have to hospitalize them, they are a little lower than where they started. So just real quick. Just a little bit about our clinic. So obviously, you know, disease-specific clinics in the community are more and more prevalent. You know, you hear people talking about going to atrial fib clinics, heart failure clinics, all kind of different specific clinics. So in 2018, our heart failure clinic saw about 9,000 scheduled appointments. So that's a lot of people. You know, I told you about when we started in 2013, they kind of, Guilford County and Moses Cone came together, and they, you know, saw a need to serve especially high-risk heart failure patients that were not responding to traditional interventions. So these people, either could not get home health, or as many of us know, they wouldn't let home health into their house. You know, some issue was there that they weren't responding to therapy. And so then they developed the heart failure program along with community paramedicine. And like I said, it was a little bit more disorganized at that time. Okay. So Katie wanted me to include this because I think many of you guys don't know what THN is, or Triad Healthcare Network. Does anybody know? Don't read my slide. So it's an accountable care organization. So, you know, it kind of works alongside Moses Cone to help people stay well in the community. That's kind of like the short of it. They work through community primary care providers. So whenever, you know, we talk about THN, they always refer to who's the person's primary care provider. And all primary care people don't participate. So they do have to pay, I think, a small fee. The patient does not, but the primary care physician does. And they're accountable for some metrics, which are tied to preventative care. So did they get their flu shot, you know, that kind of stuff. All those metrics they look at for that primary care provider. They also just recently started offering insurance to Medicare populations, and probably will soon offer insurance for Medicaid populations.
One key thing with accountable care organizations, it's really, it's the future of healthcare. This is the direction that all healthcare is really going in. And they want to focus, right now, our healthcare system is a sick model. It focuses on illness and sickness. It's a fee for service. So if you think about it, you know, if I'm going to get paid more money to have you come in the hospital more often, you know, it's not really working on keeping people healthy, right? So healthcare is kind of taking a shift to now, rather than a fee-for-service sick model, into this wellness model, and that's where these ACOs come in. They're going to provide a lot of care management services in the community. So that's why this program is so valuable to an ACO, is because we are focused on keeping people out of the hospital. We're focused on keeping them healthy, addressing the issues that are preventing them from being healthy. So that's really what an accountable care organization, and now Medicare sees it, Medicaid sees it, that this, hey, wait a minute, they're onto something here. They're not making money, they're saving money. So healthcare really is about saving money, and that's what these accountable care organizations are able to do.
So the big thing about THN is they were awarded as one of the top U.S. top ACOs last year, and they saved $15 million for our healthcare system. So, you know, you start talking money, we always tease, you know, everything's about money, obviously. So they saved $15 million. They also financially support the community paramedicine program. So they help pay these guys.
And then that's because, again, that this program is saving healthcare dollars. You know, with the work that you guys do, you know, on the emergent end, and then we're picking them up once we're identifying that they're a high-risk patient, and these guys going out to the home and kind of calling back to us and kind of triaging in the home and making a difference there. We're saving money, so it is worth it to THN to pay for the community paramedicine trucks, to pay your salaries, because they're saving more money than it costs to pay for this program. So there's, in the end, healthcare dollars saved, so as well as lives.
Yeah, that's the big thing. It's the right thing to do for the patient. Yeah. Currently, you know, this basement room, everybody that we have on our you know, list of patients that we run, I think it's about 70 or 75 people right now. They're not all THN patients, but THN still invests in the program enough that we don't have to exclude a bunch of people for that, right? You know, for that reason. It's about probably 60-40 right now. Yeah, depending on the day. So the other big thing to know about this is, you know, obviously the hospital is penalized, meaning, you know, by Medicare, right? If our admissions are above a certain number. Is everybody kind of aware of that program? The readmission?
Readmission.
Yeah. So if the patient comes in, they're there for 5 days with a heart failure admission, you know, we diurese them, send them out. and then, I don't know, 5 days from the day that we send them out, they break their foot, break their femur, I don't know, something. And they have to come back to the hospital. The hospital can get dinged for that, you know, it counts as a readmission. Not necessarily avoidable, but it still counts for readmission. So there's a certain percentage of those that we're allowed every year. And if we pass that percentage, whether it be 17, 18, 20%, then the hospital does not collect all of the money that's available to them from Medicare reimbursement. So, you know, obviously there's a fine line that we kind of teeter-totter. We want to be just below that readmission number, and we realize that the hospital has to make money for admissions. I mean, we get that, right? They don't stay in business if we don't admit people to the hospital. So all of that plays into this. This is where you start story. Okay, so Jackie's going to talk a little bit about what our roles are in the heart failure paramedicine program, and then obviously social determinants is her thing. So,
I'm the social worker in the heart failure clinic. Oh, hey, Katie's here. And I've been a social worker for 26 years. I've done a variety of social work, but all within medical. I've worked in an intensive care unit. I've worked in the emergency department. And now I have been at Moses Cone for the past 4.5 years in the heart failure clinic. When I started, I really knew nothing about heart failure. And now, you know, 4.5 years later, I've considered going back to medical school to become a cardiologist.
Or surgeon.
But, well, I mean, I'd really like to be a surgeon, but that takes too long. So anyway, this team is just fantastic. You know, social determinants, everybody always thinks, you know, as Daphne said, that that's my area. But it's really all of our areas, right? I can't do what I do as the social worker on this team without all of you guys in the field, and without the paramedics on our team, and without the pharmacist, because social determinants affect each and every one of us. I'm not a big fan of the word determinant, but that's the latest buzzword, so I like barriers. So what are social determinants? Social determinants are conditions in the environment which people are born, live, learn, work, play, worship, age, that affect a wide range of health, functioning, and quality of life outcomes and risks. So some of our social determinants, there's absolutely nothing we can do about it, right? It's just, we were born into it. Some of those things are, you know, economic stability. What kind of capability do you have for making money? Which goes back to education. What kind of an education did you have? If you were born into, there's a video that I love. Has anybody ever heard of the $100 race video? It's a bunch of teenagers, and it's at, I don't even know where, it's at some kind of a camp, trying to help kids kind of understand the differences of how we all start off in life, right? And so the kids all line up on this line, and it's a race. You know what I'm talking about? And so there's different questions that are asked, like, you know, where did you come from a two-parent household? So you get to take a step forward if you come from a two-parent household. And it goes through all these different things. Did you, you know, were you on food stamps? Were you able to get a college education? Did you have access to a private tutor during your high school years? And so for each one of these questions, you get to take a step forward, right? And then after, I don't know, 10 or 15 questions, the guy tells the kids, okay, now I want you to stop. Those of you that are in the front of the line, turn around and look at how many people are behind you. And the kids that are in the front of the line, there was absolutely nothing that they did to get to that point. It was just exactly where they were born, where they lived, where they learned. There was nothing that they did that gave them that advantage. And so I just think it's a great lesson for particularly for us as healthcare to stop and say, wait a minute, you know, not to be judgmental about some of these social determinants that people are faced with. They are real barriers that prevent them from being healthy. So at any rate, the neighborhoods and the environment, your health and health care, your access to health care, I always use a very simple example. You know, a gentleman is admitted to the hospital, and when he's discharged, the nurse hands him a prescription and says, your follow-up appointment is next week in the heart failure clinic. Have a good day, you know, you're free to go. And he's got no way to even get home from the hospital. Who's gonna greet him when he gets home, right? How is he gonna get that prescription? You just handed him a paper prescription. He's gotta now get it to the pharmacy. Does he have the money to even pick it up at the pharmacy? Does he have transportation to get to the pharmacy? So all of these are different barriers. Sometimes they can't do any of that. So now we've just admitted him, we've gotten him healthy, but now we're sending him back out into the community, and he doesn't have the capability to do the follow-up. So what happens? He comes right back again. So we've accomplished nothing. Send these guys out, and they get out to the home and go, wait a minute, they can call right back to me and Daphne in the clinic. This guy doesn't have he's got no meds. He has got no way to get, he doesn't even know when his appointment is. He can't read or write. So these are the types of things that we're able to really hit head on and try to address these issues, and then come up with long-term solutions so that they're not continually faced with this same thing over and over again. Getting them insurance, getting them you know, ongoing transportation. Yeah, we can get them to the heart failure clinic by calling a cab, but that's a Band-Aid. We're working together, and how we do this is through our multidisciplinary team meetings each week. We all come together and we go over the caseload. Each one of our 3 paramedics has a caseload, so they know their patients inside and out. They know what their needs are, what their barriers are, what's preventing them from being successful with their heart failure regimen. So we meet once a week. The THN project manager joins Daphne and myself and the paramedic. When needed, we also include our pharmacist, who's able to help us get access to some of these prescription drug programs that will help them get their medications for reduced costs. We talk about their upcoming appointments, what's needed, how we're going to make sure we're going to get them to that upcoming appointment. When they do come into the clinic, I will meet with them along with the paramedic, with the provider, so that we're all on the same page, making sure that we're helping this patient kind of gradually become more and more independent with their heart failure regimen. And then, of course, obviously, we're addressing some of those social barriers that the patients are affected with. Stay over here. So this is a little bit about our pharmacist. She works with the medications, but most importantly, she really helps get them on those prescription drug plans. There are so many out there that I'm aware of, but I don't always understand. Half the time I can't even pronounce the names of these medications. So if working with the pharmacist, she can help me so that we can then help the patient get on some long-term prescription plans. This is Daphne, I'll let you kind of jump in a little bit.
So Jack and I both kind of, you know, we consider ourselves program coordinators. Obviously, like I told you, when we both started about 4 years ago, the program was not, I mean, we didn't have 3 paramedics. Katie wasn't here yet. We didn't have the organization that we do now. I'm also responsible to kind of identify heart failure patients hospitalized. I educate those patients in the hospital. Refer them to the clinic if that's appropriate, but I do make sure if they don't come to our heart failure clinic that they have follow-up somewhere in the community. My preference is for that to be with a cardiologist and not just a PCP, particularly if they have you know, advanced heart failure or an EF less than 30%. You know, they're pretty sick folks. We insure, and I said all that. The other big thing, you know, we have the Heart Failure Fund. I don't know how much you guys know about that, which is privately donated to our heart failure clinic. And there's about, gosh, I don't know, a bunch of money in that right now. And we use that for, Jack will probably speak a little bit about this in a minute, but we use that for a myriad of different things. The biggest thing that I kind of make sure when patients are leaving the hospital is just like she said, if I go in and talk to the patient, he says, or she says, you know, I don't have a way to get these medications. This heart failure is new to me. I wasn't taking anything before I came in. And I know they're going to go home and they're going to, you know, whatever their insurance might be, they're going to face 50, 60, 70 bucks worth of meds. And you guys know a lot of these people, they can't even pay for food, so they're not going to buy these medications. And I know if they don't buy the medications, they're going to turn around and come right back. So I use this heart failure fund to fill those meds for them, the heart failure necessary meds.
So this is a little bit about what I do. I do a lot of case management and program coordination. When the when the paramedics are out in the field and they identify that there's some kind of a social barrier, whether it be that there's a substance abuse problem, we'll try to get them in. I'm sure many of you know that that is a huge challenge, trying to get people into some of these substance abuse programs. But address the issues, the housing, insurance, and then again, I make that joint visit with them in the clinic as well to make sure that we're all kind of continuing with that care plan to help that patient be successful with their heart failure regimen. Now, the fund, in addition to medications, we have a lot of freedom with this heart failure fund. Thank goodness. Because we've had patients who their power has been off, and they may have the ability to kind of manage their medications. They may have good family support, but they just simply don't have the finances, right? And they can't keep up, and their Duke power bill may be turned off for whatever reason. Through this heart fund, we're able to call Duke Power and boom, get that power restored. You guys think of some of the other examples of patients that we've kind of had some really unique
housing, like if a patient is got to get kicked out of their home or something like that, give them hotel rooms for a month. You got it.
Yeah, that's through the Hopes Project. Is another program. Yeah. So that's a great one. So we had this gentleman who was in this program called the Hopes Program, and that is they pay for a hotel room for people who are homeless that have some type of a medical situation and are not really safe to go to the shelter. So they'll pay for a hotel room for the month. And so this gentleman, he was like super resourceful. He was out there advocating for himself, trying to find some new housing. He got his Social Security, an advance from Social Security on his disability so that he could pay for some new housing because he didn't have the money to pay the down payment. He went to Greensboro Urban Ministry and got them to pay the first month's rent. But he had all of his stuff put in a storage unit, which he ran out of money. He wasn't able to pay. He couldn't pay the fees for the storage unit, and it was about to be locked up, and he wasn't going to have all of his furniture and all of his belongings. And it was like $150, and he was going to lose it all. It would have been far more expensive to try to somehow replace all of those items once he finally got in than it was to just pay the $150. But there's no, if you try to reach out to all these community resources that help people who are in financial need, they are not paying $150 for a storage unit because that's just not in their list of we'll pay for these things, right?
Non-essential.
They'll only,
non-essential.
yeah, they're only going to pay for rent and things like that. But if you think about it, if we could just put this $150 out, like now this guy's going to be completely 100%, on his own independent. I have not heard from him in a week and a half since he got into his own place. He was literally calling me 3, 4, 5 times a day for the past month. I have not heard from him in a week and a half. We paid that $150 storage thing. He was able to unload all of his stuff out of that, maintain it, and now he's out back in the community. He's got an income now. He's got insurance now. You're still seeing him for some of the medications and things like that. But he's not calling me 3, 4, 5 times a day. So we've made some successes in that regard. Hopefully, we'll continue to make successes with Zach going out and going over his medications and tackling some of
The
those
other important
issues.
thing though to say is like, we don't make these spot payments for things without like a long-term plan. Jackie's very good about making sure they have a way that they're going to get income, and she investigates all that down the road to make sure that we're not just paying this $150 bill and then next month they're going to have a $300 bill and we're going to pay that one too.
So a great example of that is Zach had one who had his car was impounded, and so we were juggling. Is it worth it to use this fund and get his car out of the pound, he didn't have an income. So if we got him his car back, the car was broken. So now we have to pay to get the car fixed. He didn't have money to pay the insurance on the car. He didn't have money to even put gas in the car. And was he homeless or he? He's living at service center. Yeah, so he's living at a shelter. So he really doesn't even have anywhere to park the car. So that was a situation where there was no long-term plan for how he was going to be able to continue to maintain his car. So it wasn't worth us to pay the monies to get it out of the impound lot, because it was just going to be right back in there again. So that would have been money thrown out the window. So we do take our time, and through these multidisciplinary team meetings that we have, we talk through all of this stuff. So I can't do what I do without them, and they can't do what they do without coming and meeting with us. And so that's why we're so successful, is that we really work together as a team on each and every patient. There's a little bit about some of the heart failure education. Daphne kind of does a little bit more about this than I do.
And this is some of the, I'm sure you guys are not talking about that in your presentation, but this is some of what we we like for them to become independent with each of those things. We don't have to belabor that. So this is the results of a research that was done. We wanted to, like, are we really making a difference? You kind of get into the nitty-gritty of our meetings every day, and at some point you sit back and go, like, is this working? Like, are we really making a difference? And guess what? We are. It's working. So obviously the graphs, I know they're hard to read, I apologize for that, but so we've done more research since this, but this is kind of and it aligns with this. But when you look at the 3-month period before the program enrollment and 3-month period after enrollment, I think we looked at about, is it on there how many people? Anyway, it's like 60 patients. This was about a year ago, guys, is that right? That we did this? And you see that of the people who were enrolled, 53% had a reduction in hospital, or 53% reduction in hospital admissions, and 25% reduction in ED visits. And then THN made a control group which consisted of similar type patients. So heart failure, they may or may not have been in the heart failure clinic, but these were all, some of the patients were attempted to be enrolled into and for whatever reason they couldn't, they moved away, something happened anyway. So of those people, they increased hospital admissions and ED visits. So this just really speaks to the fact that the program works. If we can get the people in, we can get them, we can see them regularly, then they stay out of the hospital, which is what our goal is. We'd love to have a way to look at mortality, see if they live longer, but that's a little bit harder number to get for us. But we're really proud of this, and obviously, like she said, we couldn't do it without the community paramedics and all of us kind of coming together.
I think, too, one thing that is that some of these patients we're never going to make a significant impact on. Yeah. Simply because the social barriers are just beyond the availability of resources. Mental health plays a huge role in that as well. And then the heart failure diagnosis. Heart failure, as you saw on one of those earlier slides, heart failure is a downward trajectory. What our hope is, and they all tease me, but our hope for this program is to keep them healthy, happy, and at home as long as possible. And we certainly couldn't do it without these 3 amazing people. So kudos to the 3 of you. And the leadership here of EMS, I think that's the...
Yeah. Any questions about what we do, our role? Yes.
What is your ratio of return from what you put in it? In other words, how much annually is it costing to get that amount of decrease?
In terms of like what THN invests, because realize
investment overall, as far as monetary commitments, time commitments, our commitments, things like that.
I'm not sure. So I know that if you consider, and I think the number that they tell us is about $10,000 each admission. So you look at we'd have to pull that number separate, but I think the return on investment is good, or they would continue to do it. I think we have to be making a difference.
Yeah, and I think these percentages obviously have a financial equation to them that we just don't have have that information, but,
We
you know,
try to get it.
53% reduction in admissions is huge.
And remember that it's not just about saving money. It's also about the Medicare reimbursement, like we talked about. So we keep the people out of the hospital, then we allow more money to be available to most you know, if we don't get penalized. So it's kind of like having more money on the table. And we haven't really drilled down to look at like return on investment.
But I think the thing for me is, you know, social workers, we're not typically going to look at the money. The look on those patients' faces, and there's one in particular that I'm thinking of right now, is we helped move him into his own housing. We literally helped move him through stuff on our cars and carried it in, you know, and loaded his new home with furniture. And I have a picture of us sitting on his couch. Look on his face to be independent, living in his own home, and not on the streets. That face is just worth it all. So there's got to be a tie to mortality, improved mortality. We haven't quite proved that yet in research, but there has to be.
You touched on it a little bit, but how do you pull or get patients into the program? Is it you guys look at kind of hospital patients when they're coming in for CHF and then kind of go, okay, maybe they're a candidate, or do you ever get recommendations from the field? Like if, you know, we pull up a call history for a patient and they have CHF and we're like, oh, hey, we're out here every 4 days.
Yeah, usually Katie, somebody will email Katie, she emails me and I'll look through the chart. I will tell you that right now it's confined only to the heart failure clinic patients, because what we worry about is, you know, let's say we spread it to heart care at Church Street and heart care at North Line. What misses, you know, what's missing from that is Jackie and myself and the coordination that we have with our APPs, our providers, and the pharmacists. All of that is not available there. Does that make sense? And so we worry that Katie's like, a lot of times what happens, these guys will tell you, they could be in the home, they have an issue, they can call us, or they call you know, our clinic, or they call
And
Erica.
the physician oversight too.
It's fixed. Does that make sense? So without that, in other places we lose that. So, but in terms of like referrals, I would say I probably find the lion's share of the patients in the hospital. And then secondly, our heart failure clinic, you know, visits, people who are not already enrolled, who they come in. We had a lady just yesterday, I think, day before yesterday. Erica, the pharmacist, I called her on the phone. She had a recent visit. She's on a bunch of new pulmonary arterial hypertension drugs, and she's all over the place with the drugs. She doesn't know what she needs to be taking today. We don't even know if she has them in her home. She got a referral. See what I mean? So like it's right now we don't have like a hard and fast referral process. If we see the patient in the clinic, or if I see the patient in the hospital, and I kind of talk to them, you kind of get a sense of they have it or they don't. You know what I mean? If they can recite back to me, yeah, I'm on lisinopril, they tell me all the stuff they're on, or if you know, they say my wife's in the home, she's in good health, she takes good care of me, she knows all my meds. You know, there's some little things that you talk to people and kind of get a sense about whether or not they understand what heart failure is and they're doing the right things in their house. If that's not there and I can refer them to the clinic, then they get a referral to paramedicine.
Okay.
I know that's probably not exactly what you wanted to hear.
Basically,
You want like a protocol. I don't have it. It's up here.
if somebody has any one of a risk
Social
factor,
determinants, yeah. 100%.
any one of these social determinants, and they are a heart failure clinic patient, we're putting them in paramedicine. We fortunately, because these guys are so great at kind of working through, we try to get people, graduate people, so that we can make room to bring in new people. So we have a very liberal referral process.
If I see somebody in the hospital 2 or 3 times and I go talk to them, like I know one lady in particular who I talk to, she tells me all the right stuff when we talk, and in about 2 weeks she comes right back in the hospital. I say, are you taking all your medicines in the home? Oh yeah! No. And unfortunately she's not one of our easier patients to deal with. She oftentimes doesn't let them in her house, but she's got some psychological things going on, you know, but she puts a good front on in the hospital and everybody thinks, oh yeah, she's got it together. No, she doesn't.
So these heart failure patients that are outside of the clinic, that are like at the North Line one, when they are admitted or they are coming back and forth, this readmission thing, are y'all getting penalized for that even though they're not a clinic patient?
All heart failure.
So our clinic, we see the sick of the sick. So we are the advanced heart failure clinic. So some of our patients come from Northline. So when their heart failure is on that decline, and the general cardiologist will refer to our clinic. Not all the time, but so we see kind of the more challenging, the sicker heart failure patients. So we kind of have the sick of the sick and the challenge of the challenges.
So oftentimes this patient comes in crashing and burning, they're in cardiogenic shock. We get those patients, they're all referrals to the heart failure team inside the hospital usually. If they're frequent readmits, their creatinine's going up, they're de-escalating medications, they refer them to our clinic. But yeah, so all heart failure we get penalized for, in the hospital, actually the health system. So currently we're kind of trying to partner with Aliments to help them out because they've been penalized the last few years. I mean, well, I say that now they're associated with Cone, but their rate's really high. I think they have about a 25% readmission rate right now, and Cone's about 17%. So we're trying to figure ways to, kind of help their processes over there.
And your coworkers here have been very helpful in
Mentoring, yeah.
trying to get. We want to. You guys have become the example. Everyone all around, all the surrounding counties, they want to copy this program. So they've come and shadowed them. They've called us, and we actually are almost there of getting a program out in Alamance County with their EMS. So it's kind of exciting. You guys have really been the leaders. We went to a conference down in Charlotte, all of us, and presented this program, and we were the only one that does it the way we do it. There's only a few other programs that tackle heart failure. Most of the community paramedicine programs are focused on the opioid crisis. But few others do heart failure, but nobody does it like we do it. And we were able to show, our results. And
We focus on opioid.
yeah, we've gotten a few calls.
Secondary.
Yeah. We've gotten a few calls saying, okay, now we're going to try to do what you guys are doing. So kudos to Guilford County.
So what's the next step? What's the next one? Like outside of heart failure?
Oh, that's our stuff.
Yeah.
Yeah, so
They're just heart failure. They don't.
there's a lot of talk, particularly within THN, of expanding paramedicine out to other disease specific. So it's coming. But
Hold on, we'll talk about that.
Oh, they're privy to information we're not privy to. Sorry.
Is there any other questions for us? We'll be here.
We'll hang out for a
Well,
little.
all right.
Thank you guys for your time and attention.
Thank you.